Ciambra. I am the supervisor in the treatment unit here at DDAP. Thank you so much for coming today. You have no idea how much I appreciate it. To begin, I want to acknowledge that DDAP has been working diligently across the department to address the needs of women and children, recognizing this as a critical area of focus. But for the purpose of today's meeting, I will be concentrating specifically on the women and children's outreach plans. Next slide. All right, I'm going to start by giving a very brief overview of what led to the Women and Children's Outreach Plans and how it all started with the federal block grant. So the federal block grant is a funding stream that guides a lot of the principles related to substance use treatment and prevention. The current block grant is the Substance Use Prevention, Treatment, and Recovery Block Grant, and since we love our acronyms around here, it's also known as SUPTRs. The objective of the federal block grant is to help plan, implement, and evaluate activities that prevent and treat substance use. The funding stream of the block grant starts with the federal government, then it goes to the state entities. So for Pennsylvania, that's us here at DDAP, and then it goes to the county level. So for Pennsylvania, that will be the 47 single county authorities that you'll hear me refer to them as the SCAs, and they do represent all 67 counties throughout the Commonwealth. And then the SCAs then provide the funds directly to the providers. So once upon a time in 1994, a mandate was placed requiring states to allocate funds to treatment and services that directly support pregnant women and women-dependent children. The term that you'll hear regarding this requirement is called the maintenance of effort. The amount of funds required to spend each state fiscal year by DDAP is roughly $6.7 million. So when the SCAs were faced with barriers regarding this mandate, they were encouraged to create these women and children's outreach plans to help build their network and increase engagement. Next slide. The outreach plan process submitted by each of the SCAs that completed it highlights the foundational activities and structures used to support outreach and referral efforts within their communities. These plans included identifying outreach materials, referral networks, and the barriers faced by individuals being served. SCAs described a range of outreach materials used in their efforts, such as brochures, informational handouts, and other public-facing communication tools. Additionally, the initial plans documented referral networks and referral network types, showing that SCAs connected with a wide variety of agencies, and I will get into more detail on that later on. Barriers to service access were another major component of the initial plan. SCAs identified multiple challenges faced by individuals seeking support, such as transportation, stigma, childcare needs, and the original plan highlights both the variety and frequency of these obstacles across the Commonwealth. As part of the ongoing monitoring process, SCAs were asked to complete 6 updates throughout the year, so 1 update every 60 days. Next slide. So as you can see here, brochures, flyers, and enhancements to agency websites were among the most utilized outreach materials across the plans. Social media posts followed closely behind, continuing to serve as an effective tool for reaching community members. One particularly creative approach that stood out to me was that somebody used the use of a pull-up banner displayed in an OBGYN office. And this was especially a thoughtful strategy, placing information directly in a space where women and often expectant mothers are already engaged in conversations about their health. I found it to be very clever and a targeted outreach method. Next slide. When looking at referral networks, several key partners emerged as the most frequently utilized. Children and youth services, outpatient, substance use, and mental health providers, OBGYN offices were among the strongest and most consistently engaged connections. In addition, a significant number of SCAs extended their outreach to housing authorities and correctional facilities, broadening their reach even further. Overall, we saw a wide and diverse network of referral partners, which was encouraging. Many SCAs truly took the initiative to expand beyond traditional avenues, reaching out to daycares, schools, and other community settings to ensure that information about available services for women and children was accessible wherever it may be needed. It was great to see such a proactive and thoughtful engagement across the board. Next slide. So I touched on barriers earlier, so I don't want to spend too much time revisiting them. However, I do want to briefly highlight that many of the challenges identified centered around overall acceptance, self-motivation, and of course, transportation. Recognizing these patterns is helpful as it allows us to tailor better our communication strategies and ensure that we are using evidence-based approaches while engaging individuals and their families. This awareness will continue to guide how we shape outreach and support efforts moving forward. Next slide, please. All right. So as you can see here, most outreach efforts focused on disseminating information, primarily through brochures, flyers, and similar materials. However, many SEAs also went well beyond basic distribution. A significant number held meetings dedicated to their outreach plans, developed presentations, hosted networking events, and offered specialized trainings to strengthen engagement and awareness. Overall, they did a truly exceptional job demonstrating strong initiative and a thoughtful, well-rounded approach to outreach across their communities. Last slide. So if you have any questions or comments, please feel free to drop them in the chat or reach out to me directly. My contact information is here on the screen. I am going to move right along and introduce our next presenter. This next presentation comes from one of our SEAs. The presentation will highlight how Armstrong, Indiana Clarion Drug and Alcohol Commission engages pregnant women and children through targeted outreach efforts and how they build and sustain partnerships with agencies serving these populations. So Mandy Cochran is the case management supervisor at AIC, and take it away, Mandy.
Thank you very much, Kelly. I'd like to thank DDAP for the invitation to share a little bit about what we do in our corner of the Commonwealth. So for some of you, I saw joining, putting your entities and your name and position in the chat. You may not be familiar with how all of the SCAs function and operate. So I thought it might be helpful to let you know that our SCA is a private nonprofit. We do some services in-house and contract out other services. So we contract out our treatment, and in-house we provide prevention services in the schools and communities. Our case management department is in-house at the SCA, doing level of care assessments, referrals to treatment, and ongoing case coordination. And we also have certified recovery specialist staff who are in the community and also at our recovery centers in our counties. And then we also have our admin and fiscal, because where would any of us be without admin and fiscal, two key pieces to make everything flow well. So the conversation and context for today is kind of everything you see on the slide. And I really want you to know that this is a really team effort across all of our departments. Next slide, please. So when we look at our focus and our priority for pregnant women, women with children, families, is to really meet them where they are.
Can I ask you something?
Sure.
Okay, sorry.
Was there a question? I apologize.
Okay.
Could everybody mute their microphones? We're getting some ancillary conversations. Appreciate that. Thanks. Please continue. Sorry about that.
You're on mute, Amanda.
Oh, I don't know how I got muted. I apologize. Our focus is really to meet families where they are, make them easy to find and access. So we make that happen by being present in community spaces, building relationships, ensuring our services are visible, approachable, and family-centered. Some of the examples of our outreach are events such as the Family Olympic Night, interactive family activities promoting connection and wellness, playground grand opening events, engaging families in safe, supportive community spaces, the Ag Summer Safety Day, living in a rural area. We want to make sure that we're out there providing that education and resources to families in our rural settings. Of course, family festivals and fairs, who doesn't like a good festival and fair, giving that high visibility and outreach to share services and supports. Another key one in our rural areas are our trunk or treats, family engagement in a fun, low barrier environment, so that there are lots of treats and lots of families coming through and having those resources that you can pick up or engage staff in conversations. We also do a lot of orientations as far as back to school bashes, Head Start, pre-K, sixth grade, high school. A lot of those transition years are key ways we engage our families. National night outs, partnering with community agencies to promote safety and prevention. Save a Life Day, 5Ks, other community events, so that we focus on the wellness and gatherings. We've also targeted business expos because we know parents work. So partnering with employers and meeting families there as well. Our prevention staff are great at finding activities where you can speak to parents, children are present, and then they can all engage in conversation. One of our favorites is painting for prevention. Whoever doesn't like an art activity where you're focused on painting and also engaging in casual conversation. Basketball tournaments, football games. Another good one was a healthy habits huddle where they had activities and games and resources and shared our services. Two of our big key ones that I think can be most impactful for people in recovery are the Women in Recovery parenting classes. These are online and virtual. They are scheduled in the evening, typically when our littles are headed to bed or are in bed, and it's led by a clinician. These classes are unique because there are special nuances that people in recovery navigate when being in recovery. How do you repair, rebuild those relationships? How do you parent whenever you've done and experienced a lot of behaviors that might have created harm? And so a lot of it is working through rebuilding those relationships, learning new skills, redirecting back to therapy if you're still working through some of that guilt and shame that sometimes come along with that. And then there's also the recovery parenting support group held at our recovery centers that are peer-led. So you can go and meet people that are in the same shoes you are and kind of bounce ideas and feedback. And the parenting support group is non-clinical in nature. On the slide that you have in front of you is one of our prevention staff's Carnival of Choices events where they engaged families. And if you can go to the next slide, you will see also some of the other key events that our staff have provided. Next. This slide is a little detailed and involved, but really partnering with agencies and cross-system collaboration. So ensuring that we can maximize resources and programming to bolster and support our pregnant women and children are very important. It's strengthening intentional partnerships, engaging consistently with agencies across health, human services, education, and recovery systems to make sure they get support wherever they enter care. So some of our key partner agencies are health and medical providers. Hospitals are key because you have
Okay.
various
Well,
departments.
we'll have to reschedule anyway because I'm in a training.
Key hospitals, key departments within the hospital systems where we would engage women, children, families. Our obstetrician and gynecological offices in our counties, pediatricians, primary care. Some examples of things that we've worked on and highlighted through the years is we worked with a program called Smart Choices in our one pediatrician's office. And so they would do some SBIRT, and they actually gave a tablet device to children to take some screening services for mental health and SUD risk. And then based upon that information, the provider would do some brief intervention, and at times make referrals to services, whether it would be for parents to seek out help for their children or adolescents who may be at risk for mental health or substance use risk, or sometimes they would be engaging us for interventions and assistance with referrals to treatment services and evaluations for the parents as well. Other entities we've worked with would be your children, youth, and families, and their contracted provider agencies, because they provide a wealth of services to families that they engage with. We've done joint planning for plans of safe care. We've shared service coordination, improving that communication for safe and stable family plans. We've engaged with early childhood and family supports. So in our area, that looks like Adagio Health, Women, Infants, and Children's, Head Start, Early Head Start, and early intervention, and our local assistance office staff, having those key people there so that when we encounter women and children who do not have health insurance, making sure that we can get them access to that. We engage with safety and crisis supports. Our local crisis centers and warm handoff have been key with engagement with women and families in the past. And so for our local crisis centers, they will field calls and ensure mental health is stable and not in crisis. And when they hear that SUD or resources for SUD might be a need, they will patch them through and connect them directly to our staff. And they get a one-on-one with a certified recovery specialist to walk them through services available, offer to meet them in the community or in the office, wherever they are, to engage for services and really develop that trust and rapport. We also work with domestic violence shelters, victim services. We help coordinate safety planning, connecting women to shelter resources, and reducing those barriers to treatment entry. And of course, where would we be without our recovery support staff in the community? The people that walked a mile in their shoes and can really connect on that peer level and guide them to various resources. So we engage our recovery centers, our peer organizations, parenting and recovery leaders, unlinking them to those supports and providing those groups education, and it's tailored specifically to meet their needs. So how do we build and maintain these partnerships? We strengthen them, and it's really our line staff and the support of our administration and management and fiscal teams to really drive home that consistent communication, that consistent of showing up, sharing in that training, engagement and collaborative meetings. Sometimes it's very formal education and training, and sometimes it's those informal teachable moments that case managers, prevention staff, and recovery specialists have one-on-one in those conversations. Sometimes those informal conversations are the key to change and reducing stigma that can be very impactful. And then that helps everybody. That helps the agency, that helps people seeking services and engaging in recovery. Some of the more formal and professional settings and trainings we either host or provide entities. Our drug impairment recognition, our recovery simulations have been a big part in what we do in helping educate and reduce stigma and brainstorming together with other agencies to solve problems and barriers. Science of addiction. And when I think about our recovery simulations, we invite everybody from our local legislators, line staff at other human service agencies, hospitals, our legal entities, probation departments. We kind of invite everybody and anybody that we can think of, including community. And what we hope to achieve is to get everybody to go through this once so they can get a clear picture, an idea of what it's like for a person in recovery. And then when you're from a human service agency We ask you to then participate and volunteer so that when people are coming to your station because you are the assistance office or you are probation, they can get a feel of what it's like to engage with you and see you as a person helping somebody else in need. That has been a key way to maybe open people's eyes to fully understand that there is so much to the disease of addiction and working people's way to recovery that you just don't quite grasp it all, but it will open your eyes to various problems and things that people in recovery experience. And it has promoted change. So for one of our simulations, one of our legal groups that attended had recognized that the idea, if you did not have an identification, it would limit your ability to get a job. It would limit your ability to engage in treatment or medicine for the disease of addiction. And so we broke down some barriers together and especially upon release from jail. Another one of our staff, bless her, decided to plant substances on one of our local legislators. And so that ensued dialogue about repeating and return to use, also about some barriers on transportation. And this legislator has been a real champion at listening to people in recovery and what their needs are, and also tailoring things for pregnant women and their families as well. So that has been key. Thinking about some of our meetings and work groups, we participate and engage with partner agencies in plans of safe care. And I'll talk about that in a minute, but that's just working together with people who suffer from addiction and working to get them to recovery and be safe with their families. Human resource councils, they've been a great resource to work with. Our consortium partners for neonatal abstinence syndrome, our service provider advisory task force, various coalition meetings, shelter task force, our children's roundtable that our children, youth, and family agencies host with other key leaders in our county, our local career link for employment, daycare centers. We've also participated on some advisory boards with children, youth, and families, helping them break down barriers, find programs to help people get well, get on their feet, achieve and sustain recovery, and keep the family together, which is really important. So working through all of these things really helps us provide that connected network of care, identify people who might need services earlier, engage them sooner, and help them build that recovery capital they need. We've created stronger warm handoff pathways so that there's really no wrong door. Just get here and we will help you get what you need. It's fostered deeper engagement by people and services because we all know who the key players are to help you with the resources you need to be successful. It's strengthened support across agencies, across professionals. It's provided enhanced service delivery, so it's timely, it's clear, it's effective. We've reduced stigma over the course of time, and hopefully we will be collecting data together to provide better outcomes and show the outcomes and the work that we do is making a difference. Next slide, please. So, sustaining the visibility through programs and partnerships. These are some of the bigger ones. There's also some other ones that we have worked with and through. And of course, when you're in the field for a while, funding streams come, funding streams go. You find evidence of better and new ways to do things. So things continue to evolve over time, which I think is really important when we look at collecting data, looking at studies, following those evidence-based practices. So some of the things I have highlighted here are the plans of safe care teams. And those of you across the Commonwealth have probably heard plans of safe care and the initiative involved. So in Armstrong, Indiana, we serve on the team, the Plans of Safe Care team, made up of children, youth, and families, hospitals, early intervention, treatment providers, mental health, SUD, resource providers as well that CYS contracts with, and we as the SCA sit on the team. And on these teams, we meet whenever there's a woman in need of a plan of safe care to make sure that the newborn and she are safe. We also meet and talk about education, trainings, how to outreach to ensure timely referrals, making sure we have all the resources that people may need. We do education and training. We meet quarterly and review individuals that have come on our radar for plans of safe care. We talk about process. We talk about barriers. We talk about what went well, what we want to enhance, and maybe where we need to pivot and do something different. In Clarion, we don't sit on the team that does all of the things. However, whenever CYS is made aware that there is a woman that has delivered and we need a plan of safe care, we are invited into that hospital room via Zoom, and we talk about the services we offer. We talk about engagement. We talk about in-person versus telehealth, how we can support the individual in recovery, and using those resources together to ensure that they are safe. The next item on the list is Adagio's grant. And this one is a mouthful, but it's Health Resources Service Administration, HRSA. And it's an RCOR grant. And RCOR is Rural Communities Opioid Response Program, and it's the Neonatal Abstinence Syndrome grant. And this grant serves Armstrong, Indiana, Butler, Lawrence, Mercer, and Venango. We are consortium partners with Adagio and some other entities in the other counties, and our purpose is to reduce the incidence and impact of NAS in rural communities by improving systems of care, family supports, and meeting those social determinants of health needs. Our goals, we try to reduce the structural and system barriers, things like transportation and workforce. We want to strengthen quality and sustainability of behavioral health services in our areas for pregnant and postpartum persons and their families. The next item on my list is Service Provider Advisory Task Force. And this is a key piece to how and what we do. It's typically management level, SCA staff, and contracted treatment providers that we utilize for substance use disorder treatment. And we meet together either monthly or every other month, and we talk about trends that we're seeing. We talk about if referrals are increasing to where we're nearing capacity. We talk about what we're planning to do if we hit capacity to serve individuals. We talk about training needs, evidence-based practices, talk about trends that we're seeing, concerns, barriers, and then we work to problem solve any concerns and barriers that we're receiving and hearing about in our communities, and find ways to work seamlessly whenever possible, serving women and children. Our Hospital and Human Service Council meetings are also a key component of what we do, especially the Human Service Council meetings. Our line staff typically attend those, and we share our services with other like entities in the human services field, and we also learn about what the services and programs they offer so we can make appropriate connections. And that's whenever the professional dynamics and relationships with line staff form. And that is key, because then you know exactly who to call, and you know their number, you know their email address, and when you're sitting together eating lunch, you start to learn and have those informal teachable moments with each other. Hospital meetings are important too, because we have the warm handoff programs in all three of our hospitals. We do education and training during new employee orientation at our hospitals, discussing our services, how to make referrals. We talk about trends in data with our hospitals at our consortium meetings each month. We talk about the number of SUD referrals, what units they came from, did people engage in services, how did they engage in services. We talk about any trends that we're seeing, new substances on the horizon. We will seek out information and training on those substances and trends that we see. And we also break down any barriers or problems that we've encountered so that we learn about things and address them in real time. The last two are very near and dear to me and have been very important over the years. The Jewish Healthcare Foundation had listening sessions this last year, and they partnered with the PA Perinatal Quality Collaborative. And what was really important was doing an environmental scan, hosting listening sessions, and interviewing pregnant women or women who recently delivered in the rural areas to see what they are experiencing, what barriers they have encountered. And this was important for us because in Clarion County, we're part of a maternal desert. There is not a hospital where you can deliver. And so women in Clarion County will travel anywhere from 40 minutes to over an hour to a hospital to be able to deliver their child. And so the PAPQC is going to work with the hospitals in the areas once they've completed the environmental scan and all of the interviews and compiling the data to talk about services and offerings to women and pregnant women and children. What our agency took away was listening to those moms directly. Here are the barriers I've encountered. Here's what I would like to see. Here's what I need. And then also we learned where they went to deliver to start really working on cultivating those relationships in nearby counties to partner and offer services as well. And the final one is our MOMS program, the Maternal Opioid Medication Support Perinatal Program. And this is a partnership with Indiana Regional Medical Center. It's the physician group, and we provide support for expecting moms struggling with addiction. It provides prenatal care, postpartum care, medicine for alcohol use disorder, opioid use disorder, and if needed, mental health medicines. Counseling, a recovery support specialist who is a mom in long-term sustained recovery, which I think is really key. You need somebody that's walked a mile in your shoes to really identify and connect with. And then you also need the professionals that can help you with those clinical pieces as well. They also have access to case management. You meet with a social worker at every appointment. So if anything comes up between appointments, you can either call the social worker, let the social worker know during the appointment. We work together as a team to make referrals and coordinate care, get your basic needs met with community resources. You have health and wellness education, access to parenting classes as a woman in recovery or early recovery, and those parenting support groups. And the goal is to improve health outcomes. The other thing that is very important to the MOMS program as a team is stressing and educating to staff and making sure that women who are coming into the program make sure that they know that addiction involves cycles of remission and return to use can occur and does at times, and that asking for help can be frightening. So we use our trauma-informed approaches to care with empathy, kindness, and concern so that we want you to know that at any point in time that door is open and we're here to help you do whatever it is that you need to do to be successful as a woman in recovery. Next slide, please. So this is it. This is my contact information. If you have any questions, I'm happy to answer them. Feel free to reach out, call, text, email, whichever you would prefer. If you have questions and want to send them to me in the chat, I'm happy to answer them as well. I think one of the key pieces that I may not have stressed is it's really important to have staff that buy into that mission, whether they're people in long-term recovery who get it down to their bones, people who just love and support family, and people who are just in the helping profession because that's who they are and what they do. Making sure that they buy into your mission and are willing to open themselves up and make those professional connections is really key to success of all of our programs. Thank you very much.
Thank you so much, Mandy. You guys are doing such good stuff. I can't even tell you enough. You had me all the way at the trunk or treat as a mom of three. Like, I'm here for it. But no, thank you so much. Gonna move into our next presenters. Our next presenters come from Bucks County, and Diane Rosati, who's the administrator at Bucks SCA, is co-facilitating with Gordon Hornig of St. Luke's Penn Foundation, and they will be presenting on Bucks County's approach to women and children's health.
Great. Thank you so much, Kelly. And thank you to Amanda as well. We're so delighted to be here today and share some of the projects and work that continue to happen in Bucks County. But frankly, you know, just sitting through Amanda's presentation and then the next presentation, we have a number of staff in today's meeting. I know we're going to pick up just as many ideas from you. So thank you to everybody for being so generous and sharing, and to Kelly and your team at DDAP for arranging for today's meeting. And what a significant number of people, almost 230 people sitting in this meeting today. So clearly this is an important item. I'm going to thank you to Bethany for sharing the slides. Bethany is joining us today from Bucks County. We are really proud of a lot of the work that we've accomplished over these past several years, and we are actually a work in progress. So I don't think we're quite there yet, but we have some fantastic momentum that frankly was spurned by DDAP. Like many other counties, we had found through the years that we were not fully expending our pregnant women with children's allocations as we could have been. So we got pretty creative and put some really good minds together. And that's certainly not me, but it's our team at the Drug and Alcohol Commission, as well as other stakeholders and providers. In a few minutes, I'm going to be happy to turn this over to Gordon Hornig from St. Luke's Penn Foundation. I want to thank Gordon up front for his willingness to present and to share his project that I think has already been replicated even in Pennsylvania. So thank you to Gordon. Next slide, please. So I'm going to talk a bit about some projects that we've worked with that include prevention, resource development, marketing, recovery housing, training, transportation, etc. Of course, many women who are using substances are also, who are pregnant and parenting, are also health choices enrolled and have treatment access available to them. I see we have many partners in today's meeting that represent the MCO and behavioral health. So thanks to you for partnering with us as well. My remarks really won't focus as much on treatment, but on the other items that I mentioned. Since we hadn't been expending all of our funds, we put our heads together and developed a very comprehensive outreach plan, and I'll share just a snippet of that in a moment. But regarding prevention, and I know that the provider that I'm speaking of, Liberté, is represented in today's meeting, so special shout out to you. We have a long-standing relationship with Liberté in Bucks County, who provides services, residential treatment for pregnant women with children, as well as a prevention contract, and that's what I want to spend a moment on. So over the past year, we have funded 2 prevention programs that you may or may not be aware of, the Mommy and Me program and the Incredible Years. Mommy and Me is a music therapy program It's facilitated by a board-certified music therapist. It promotes child bonding through a series of musical activities. Those activities include impulse control, cause and effect, relationships, and following directions through music. The data, and everyone here knows that prevention is certainly extremely data-driven. The data has shown robust changes for participants regarding the areas of parent-child bonding, feeling supported, increased eye contact, and certainly increased and positive communication. The second program is the Incredible Years Parents and Babies. It's a model program in the SAMHSA registry. It's delivered in a parenting group format where parents practice their skills with their babies to help babies feel loved, safe, and secure, and to encourage babies' physical and language development. That data, also robust, showed increases in play and connection within the family, developmental knowledge, as well as increase in self-care perspective. The next slide speaks to our significant outreach for pregnant women, women with children. This is just a snippet of our resource list, which we have sent to Kelly numerous times with edits, always improving access to services. And many of the collaborations that Amanda has already mentioned. Because Amanda's presentation was so thorough, I did sort of trim mine down a bit so you weren't listening to the same kinds of services over and over again. But I do want to say that we mirror many of the stakeholders with whom Armstrong, Indiana, Clarion is working, and we're really pleased and proud of that, including not only the drug and alcohol system, but mental health, all of human services, justice systems, houses of worship, as well as libraries and community coalitions. The next part of this slide speaks to, thank you, speaks to an event that we coordinated, and I know that some other counties have coordinated such events. Ours happened to be called Baby Bump and Beyond, where we held a fair at our county building where we invited community partners to share information that might be important and giveaways for pregnant and parenting women. That was our first foray into Baby Bump and Beyond, and we certainly expect to offer that again in the future. It was a great way of helping to get the word out. Any of our flyers and social media posts, aside from her being so adept at running our slides, Bethany, who's in our meeting today, chairs our marketing committee and creates all of our media posts and flyers. So shout out to Bethany for doing that. In addition, you'll see on this slide that we have developed other services and other outreach efforts. Sort of an old school thing that we brought back was developing ads on placemats in restaurants. We have found that that is certainly a place that folks, families sometimes are sitting in a restaurant where there's a paper placemat and they can see an ad for our drug and alcohol, pregnant women, women with children services that are available. And we've printed over 35,000 of those, thanks to Kimberly London, who's in this meeting, who led that process. And you can see that the other programs that we've developed have been pretty highly successful, and we focused our social media campaigns on Women Mental Health Month and have had 8 postings during that time as well. So we've been very, very, very active. Next slide, Bethany. Thank you. Just a couple of quick comments. Finding housing, safe, sober, licensed, supportive recovery housing can be such a challenge in our community, at least, and I'm sure in yours as well. We contract with 43, it's sort of a moving target, but at this point, 43 licensed recovery houses. And in Bucks County at this time, we currently contract with 9 houses that work with women specifically. Always in the works is thinking about what kinds of services we could offer for pregnant women and women with children in terms of licensed recovery houses. But we're really happy to have 9 houses available in our county. We have a program that is overseen through our office and funded by the Managed Care Organization, by the MCO. And that's our BC Rock program, Bucks County Recovery Residents Oversight Committee. And through Bucks County Recovery Oversight Committee, we have approved and funded 424 women for a total of 55,587 days in recovery houses since February of 23, so almost 2 years, and that's a significant impact. Certainly a gap for women as they're seeking recovery housing when they leave a higher level of care, and it's something that we continue to work on and evaluate every year through an outside evaluator. That project continues to show great success. Thank you, Bethany, for moving on. Something that Amanda mentioned and I too wanted to mention is transportation as a barrier for women. And so we have been extremely fortunate, and I'll just make mention for a moment of opioid settlement funds. And Bucks County's use of opioid settlement funds has included a significant grant through Danny's Ride, which offers ride share through Uber or Lyft, where we offer 10 round trip rides or 20 rides to Bucks County residents who are seeking to be transported and don't have access to a car or don't have a license to any number of services that include drug and alcohol treatment, recovery houses, education, employment, recovery programming in the community. And we've been able to offer that over the last 2 years through opioid settlement funds. It has really been highly respected and approved by so many individuals, and we really appreciate all of our stakeholders. Quite simply, a provider identifies ride agents, our staff help to monitor the process, and we just pay the bill for the service. We have published a report that showed some of the comments by residents who said that without those services, they wouldn't be able to access any of the recovery supports in the community. So it's been really helpful. Training, lastly, is certainly a priority for us. Through our training academy last year, we held a provider training on the impact of substance use disorders and pregnant and parenting children. So I wanted to take a moment and sort of get to tee up our next presenter, who is Gordon Hornig of St. Luke's Penn Foundation. Many years ago, St. Luke's Penn Foundation came to us as we were looking at trying to get more creative about sort of some old school outreach models. And Penn Foundation developed a protocol that has changed a bit, but is still used today. I think that when we start a new program, it works for a lot of reasons, but mostly when there is a champion. And so you're about to hear from our champion. I think of our friends, and I'm glad Amanda spoke before me, Mike Krafik from Armstrong, Indiana, Clarion, who's a great example of an individual who has been able to be supported by his SCA and develop new and innovative programming that lasts and be able to respond as needs change. And so Gordon Hornig is our champion for mobile engagement services. So he has, in partnership with us as a funder, helped to develop a program that is mobile engagement services, but is also providing services for our children and youth department, which is so important. I will mention that this is one model of outreach for pregnant women. But we also have another model, which is through the Council of Southeast Pennsylvania, and that is also long-term, and that is Mothers Overcoming Mood-Altering Substances, which is a similar type of case management project. But for today, I'm very, very happy to introduce Gordon Hornig from St. Luke's Penn Foundation. Gordon?
Thank you. First of all, I just want to say, I know this is going to be a brief overview, but if you have any questions about the model or the work we're doing in the county, please put it in the chat because we will follow up with you. It's really important that the questions you ask may help us continue to build our model and evolve as we go along. So I'll start, if you can go to the first slide. I just want to give a quick history of how this relationship developed. As Diane said, we were a model that was really a general outreach initially, working with several identified populations that were in need. But we were approached in 2015 by children and youth because they started seeing that increase in the opiate use within their department and agency, which led to an increase in investigations for child abuse and neglect cases. And this was alarming for them, and they wanted to see how we could move forward. Next slide. So in their gathering of information, it was about a 5-year period, they noticed that these individuals who were using substances had out-of-home placements of children from roughly a 42 to 66%. I mean, we're talking almost half to more than half of the children that had parents that were using being placed outside of the home. And they wanted to change that in our county. And we've done a tremendous relationship. Again, not just children and youth and us, but all the shareholders in the county. And you'll see that in my presentation. But it also led to where our Commonwealth was moving in working with children prevention and treatment. CAPTA is what we call it in Bucks County. But this is really where hospitals and our warm handoffs really helped us out, because they were identifying and mandated to report cases to children and youth. And we were able to mobily get to the hospitals and begin to work on some of the safe care planning that all of us do throughout the Commonwealth. Next slide. So I just want to tell you a little bit about the model itself. And it has evolved, as Diane said, over the years, from a general outreach to a very more specific directed approach. It's a 4-point approach. It's a community-based approach that works on the following levels that you see on your screen. And I'm just going to talk about them very briefly. The engagement level is really creating a relationship with either the individual or the system. And this is probably one of the big differences from any other case management services that are well known within drug and alcohol, is that we can engage the system even if the client is resistant to help. So when you have family members, loved ones that see someone struggling but aren't ready or capable or don't have a door to engage in treatment, we will meet with them and we will figure out what door that is. And some of those avenues are just giving them information and then letting them access it at the right time. But creating that engagement period, an honest dialogue with the individual or system is really important. We then move to our what we call level 2 motivation. And I think in simple terms, it's where we put a plan together. It's where we decide what would be the best help and the quickest access point for someone to seek out services. It may not necessarily be to stop their use. And I think that's really important when we talk about harm reduction approaches, that this is a process over time. So many individuals have lost trust in our system, maybe because of their mental health, maybe because of their ongoing substance use. So we know it's going to take time. And so in building this change, it may work. This plan may work with the individual or it may work with the family. Once we develop this plan, and we do have recovery plans that we put out, and it covers basically our social determinants, our areas, just like regular case management areas. We have that input from both the family and the system because we don't want to create the plan. We want them. We're going to meet them where they're at, which I think is effective in many services. But then we work on a period of time of stabilizing that. So we take them out of this chaos that they may be happening. And I think a great example of that would be a family that feels that there is nothing else they can do for their loved one. And they may say, I'm getting a divorce, or you're out, or I can't be here, and they leave because there's substance use. And now we're having children and women that are abandoned by their loved ones. And this is really a critical step for us in slowing that process down, stabilizing it, and then bringing other traditional services in place to help them and stabilize them. And then most importantly, we know just like any fire, there's hot spots. And so things flare up. And so we want to make sure that we monitor them, which takes us to our level 4. And that period of time ranges for every single person and every system differently. You can't use a cookie cutter approach, as most of you know, in drug and alcohol and mental health. And so we work on an individual basis with that identified client or that system. And we take the time that's necessary. We have had cases that have been active and then inactive over a 15-year period of time. maybe because of their co-occurring issues, maybe because of their relapse potentials. The bottom line is we want to stick with them and build these relationships. And I can tell you, I've been in the field 30 years. It is so wonderful to see people come back to us time and time again when there's time and need, that they're not embarrassed or ashamed. And I think that's what helps us stop the overdose and deaths that happen with this particular population. Next slide, please. So what are the services that we do? So I'm just going to go through some of them. One of the things that I love is that we're actually able to go out into the homes, into the community, and we're able to assess individuals. So if a person has been identified and is willing to undergo an assessment, we are all certified, our staff, and we have 15 in our program. We work to do the assessment and do the appropriate placement for those that are willing and capable and accept it. This can be difficult sometimes, particularly when we're dealing with pregnant women with the limited resources that are available. So we'll keep this relationship going, one, if they're resistant to that help, or if they're concerned. Again, both presenters earlier mentioned housing and transportation. We will take them to whatever program is accepting of them and start that placement. But we don't stop there. We keep that relationship ongoing. So Diane had mentioned Liberté, which is, a long-running program, highly respected in our county. We will work with them and others to make sure that our staff is going and continue to build a relationship, even though they're engaged in a traditional level of care, because we know the next steps may be other hotspots that they face. It's part of the harm reduction approach. And again, I'm not going to read through the screen. I'm just going to highlight some areas. Getting individuals connected with benefits, although this may start before they go into treatment, seeing that follow through, particularly when we've already mentioned license and IDs are necessary in order to move processes through. We're able to do that even if their time and completion at a treatment program occurs. One of the really unique aspects, and I think really rewarding in working with our population, is dealing with crises as they occur. And as crises occur, I'm not talking about traditional crises. I think we do have those, and there are individuals that are placed in mental health and drug and alcohol programs because of their crises. But we're talking about crises that are acute. Like, for instance, when someone comes home and a parent sees an adolescent substance use sitting in a home, we don't necessarily want to get them into the legal system, but they may reach out to us and say, this is the right time to maybe engage them and get them into treatment. It also may be able to get a spouse. So we talked about single women and children, but many of these individuals are connected to unhealthy males in the community. We want to engage them in treatment as well. So we do this partnership with them. And again, you begin to understand where this system placement occurs. One of the unique opportunities our team, and I failed to mention, our team is made up of CRS, bachelor, and master level staff. I think that's important because that lived experience is really important to our team, but it also is important as we begin to understand more evidence-based programs through bachelor's and master programs. We want to utilize them and take advantage of them. So I think we do have a really robust staff. Couldn't be more happy. And as our first presenter said, they love doing the job. You got to love doing this work and getting out in the community because it's not for everyone. But one opportunity that came forward that we took advantage of was being trained in the ARC and ARC Grow programs. That was an initiative that was offered through Family Base and through our St. Luke's network. And we felt because of our interactions with children and single parents and families in general, that this background in trauma training would be really effective in creating better relationships, but also utilizing other services that are in place. One of our next big initiatives is also to work on brain trauma. So I think with that combination, we're going to be able to serve really a large group of individuals who in their minds are going through crisis. We do a lot of relapse prevention. We do plan of safe cares and participate in teams of that. We're we develop not only our own recovery plans with individuals, but we adopt any programs that they're involved with in traditional services. We work with street outreach programs, and we're also working with street medicine. Next slide, please. One of the unique things that you're going to see in one of the upcoming slides is how we connect with those that maybe do not have shelter and some basic needs. We also do service coordination. We respond to legal navigations. One of the big things with our adolescent programs, and it's something I really want to highlight, is that if you're not familiar with Act 53, I would encourage your communities to look at that. With our partnership with the legal system and our commission, we were able to have families seek out the civil process of getting someone mandated for an assessment. One of the biggest difficulties we have with transitional youth and adolescents is they're not engaging in treatment right now. And this is a way for families to mandate it to happen. If at the very least, we're identifying the true issues that are happening through the assessment that occurs at the courthouse. But I will tell you this, we have a 100% engagement. Having a judge oversee it and have that stipulation and legal process in place civilly, we are getting individuals for at least a minimum of 30 days engaged in the level of care. And I'll show you some additional slides in a moment that talk about the effects of that engagement. And then family networking is always important. 12-step, as Diane mentioned, some of our church support programs, not only for drug and alcohol and mental health, but other basic needs, helping with housing, helping with food, and helping with shelter, or just being a friend and supportive person, a true peer support. Next slide, please. So some of the outcomes this year that we wanted to just show you how robust this the problem is. I mean, I know I'm speaking to the choir, but I think in our county, we wanted to at least identify of the 108 referral cases we got from children and youth this year, 86 were adult cases, 64 are still engaged with us over this period of time. 20 of the cases are the CAPTA or Plan of Safe Care cases. So we know that we're meeting individuals when they're giving birth or going through the prenatal process, engaging them in services. The unique thing about this is when children and youth are engaged with a family and someone becomes pregnant, they're engaged because of the living children in their home. It doesn't stop us from actually offering additional help. We don't have to wait till that child's born. So we work with MATs and some other things I'll show you in a second. But 125 children that were affected, and this is where the ARC and ARC Grow have really come into place with the trauma, because trauma does affect these children, and if we're ever going to reduce the numbers greatly of them becoming substance abusers themselves, we have to jump on the wagon very early. 48 cases were co-occurring. These are self-reported. We also know that there's a lot more individuals who do not self-report or not in an assessment process to identify that. 45 of the 108 cases involved family engagement. So we know at least half of the individuals that we connected with, we have a family engagement protocol working for them. Again, some individuals just wanted them and they seek out treatment, and that's fine. As our first presenter said, there's no wrong door in this approach. And then 41 of the 108 cases were single parent household. So you can only imagine the social determinants that these individuals were going through. And that's where the case management hybrid piece of our work comes into play. Next slide, please. So the impact on adults, 45 clients have engaged in treatment at some level of care, which is incredible. That's a 50% rate. 7 cases with significant medical issues. This is something we're seeing more as we have our opiate users with some of the medical and infections that are occurring. It also is for the prenatal and postnatal ongoing support that we can give them. 22 of 108 refused services. Again, the individual refused services, but we were able to engage in some of these families and continue to work with them until the individual is accepting of our service. 21 families had transportation issues. And again, Diane mentioned Danny's Ride, but at times we can initially get them to a service and then get other additional case management services to pick up the role. So we don't want to duplicate existing services, but at that critical moment, we can transport them and get them to that next. And one great example is that if someone says, yes, I'm willing to go into treatment, we want to make it happen then and there immediately. Inside, these are the primary substances that have been identified. There are certainly secondary and tertiary substances that are used, but 20 cases were with meth. And if you look at the overall numbers, meth and stimulant use overall is very high in our county right now. We still continue to have opiate and fentanyl use and synthetic drugs out in the community, so I don't want to minimize that effect. And we also have at least half the cases involving alcohol. Again, these are the primary substances. Some of these cases involve all four of these criteria and categories. Next slide, please. I just want to, briefly give you a little outline of some of the adolescents and not so much children use, although we are starting to see some younger children with substance uses. But we have 21 cases came directly from Children Use Services that identified adolescent substance use. 41 cases were referred from other community resources. So we are embedded in all the services, mental health and drug and alcohol in the community. So they are making direct referrals to us when they identify women and children needs. We had a total of 6 new the Act 53 cases this particular year. As I said, all of them are engaged in treatment right now. I will tell you that there is a significant mental health attached to these individuals. We're also seeing, because of some of the lack of resources in substance abuse and treatment modalities, that individuals we find a little bit harder to place because we've had this divide, as we all know, between the umbrellas of drug and alcohol and mental health. Even though I know we're making strides, we're not there yet for sure. We only had 22 of 108 refused services, and I think that's a very marginal number. If you can have 25% of the individuals refuse, that's a pretty small amount. So I think, using motivational strategies to engage individuals is really important. And then on the inner circle, I just wanted to identify most, if not all, the adolescents are using marijuana as their primary substance. Synthetic, so it is not the same as maybe 10 years ago. We're seeing, obviously, in the hospitals, some individuals who get very sick on the marijuana. And the method of use, we're seeing high rates with the vaping and obviously smoking as well outside of vapes. So that is just some of the information. If we can go to the next slide, I just want to talk about some of the fundings what makes this all possible. And I know Diane hinted on it a little bit of how they have helped us out and how Magellan has stepped up to continue. And we're always looking at new initiatives. We do have, through our hospital, we're asking private donors to help to reach their communities. And we're starting to get some traction with that. And as Diane said, we were able to take this model and duplicate it in other counties. So I really appreciate what Bucks County has done for us, because now we're reaching out to try. And quite frankly, our hope is that with the data that we are collecting, Magellan has done a 10-year project, and we were seeing about a 96% retention rate of people staying in the community over 6 months. That's important. But we are collecting additional data, and we hope that MES will become an evidence base that everyone can use, not just in the state of Pennsylvania, but throughout the nation. Troubleshooting housing crisis, this is really something that is near and dear to my heart, is that, since COVID, we've really seen an increase in the encampment sites. There are a lot of individuals, females and children, who are at these encampment sites. Understanding that these are special needs and getting them connected is really important. And two things that I just, two cases that come to mind that I think are awesome is that we were able to get women that were pregnant in encampments, in the treatment programs, and deliver healthy babies. I can't ask for a better outcome for cases that are like that. And then finally, our marketing. Our marketing, aside from our agencies, the county has put it on their websites. We do social media, but we also have taken an approach with our different staff to get involved in other trainings. For instance, I just want to give a couple, and you can kind of see where all this connects now. We presented at the 2025 Bar Association in Bucks County. We also attended and presented at the Bucks County IU, which allowed us to reach schools and guidance counselors. We presented at the 2025 Maternal Care Coalition, which opened up multiple county contacts for us and new MAT and approaches that were current with the fentanyl use. We presented to our Bucks County Juvenile Probation for an in-house service, which was great to have them on board. We've integrated in both mental health and DNA county programs like Family Base. And finally, our administrative and local providers, such as primary care physicians, have allowed us to come in and talk with their staff, but also leave pamphlets behind. So we're trying to really reach as many populations or have them reach out to us as possible. So thank you for giving me a time to talk about our program. And again, I welcome if anyone would like to know more about it, because your questions may help us kind of further develop our programming. Thank you.
Thank you so much. Well, if you guys have any questions, feel free to drop them in the chat. But I do want to thank you, Diane and Gordon, so much for presenting. It's greatly appreciated. And Diane, I never get tired of seeing your resources. I love them. So send them
Thank you.
all the time. Okay.
Will do. Thank you. So thank you for the opportunity. And again, I want to
Oh.
publicly thank Gordon for all of his work and representing St. Luke's Penn Foundation in this project so well. Thanks, everybody.
Yes, thank you so much. All right, and last but certainly not least, we have Hannah Cristofano from Tobacco Free Adagio Health, and she will be discussing the priority population of pregnant and postpartum women, the long-term effects of nicotine use during pregnancy, what the research shows, and the Healthy You, Healthy Baby program, and what it has developed to assist
Oh, they were
this
here?
population and nicotine-free journey to foster a healthy home environment for the entire family.
Wait a minute, I want to, you want to do both?
Hannah, if you are here, I'm hoping.
Yes, I'm here.
Okay. There you are.
Okay, can everybody see that? Okay,
Yeah.
awesome. Just give me 1 second. All right. Thank you everybody for joining. I'm just going to go over a quick introduction of Adagio Health. So for some of those who are not familiar, Adagio Health is a nonprofit organization. We are based out of the downtown Pittsburgh area. However, our services span across all of Western Pennsylvania and reach most of the state of Pennsylvania in general. We prioritize working with women and families, providing reproductive health care, nutrition and food security, education, as well as lots of other services through our medical offices, our WIC offices in 5 counties in Western PA, and our breast and cervical cancer screening program that spans most of the entire state. So unlike others today, I will focus this conversation on nicotine use in pregnancy. The Tobacco Free Adagio Health team primarily works with priority populations. Obviously, pregnant and postpartum people fall into that category. But some of the other priority populations that we work with include youth and young people, those of lower socioeconomic status, veterans, the behavioral health community, people in recovery, and lots more.
Yeah.
So just to give you a visual here, the service map
I don't even know how to turn
is on the screen. You can see a lot of our services are in Western PA. Our medical offices operate out of the western part of the state of Pennsylvania, as well as our WIC offices in most of our programs. Our breast and cervical cancer screening program is unique in which it operates in most counties in Pennsylvania, except for over in that Philadelphia kind of area in southeast Pennsylvania. So lots of services focused on the western half of the state, but again, we do have that large footprint across the entire state. So to give you more information about tobacco-free Adagio Health, we are the regional primary contractor for tobacco prevention and control in 3 regions of Pennsylvania, which includes the Northwest, Southwest, and Allegheny County. Allegheny County is its own health district, given the population of people that are living in the county, but we serve all of the county our daily work. Being the regional primary contractor, we work in conjunction with the Pennsylvania Department of Health for our funding source and to provide all of the programs that we do. Our mission is here on the screen, dedicated to preventing and reducing tobacco use, increase education about tobacco hazards and secondhand smoke. We do that through youth programming, like I was mentioning, going into schools, providing educational presentations, providing interventions and treatment if students are addicted to nicotine or if they would voluntarily like to quit on their own. We offer them cessation and treatment services. We offer a youth advocacy program called the Tobacco Resistance Unit, which is a partnership with in the school, student leaders that are interested in making a difference and doing some of that peer-to-peer education about nicotine to influence positive change within the school. With that, we also work with adults who are looking to quit. So providing counseling, coaching through the Smoke Free for Life program. That is an evidence-based cessation curriculum. We also promote the PA Free Quit line and encourage people to give the quit line a call if they're interested in starting that quit journey. Providing education, again, across the lifespan, starting with the pre-K education that we do, introducing students to smoking and vaping, nicotine and tobacco education through a puppet show, and then all the way up into, visiting senior high-rises to help them quit or to just educate them about some of the different chemicals in cigarettes and other devices. Another big part of our work is policy. So making sure that spaces have nicotine and tobacco policies that are comprehensive and inclusive of vaping, new nicotine products, and things like that. We work specifically with schools, parks and playgrounds, work sites, and multi-unit housing buildings to make those policies inclusive and then help with enforcement as well. So I know that's a lot of information, but that is just kind of a brief glimpse into what our work is through our funding through the Department of Health. Today, I want to share some information that we've been working on about the priority population of pregnant and postpartum people. We're going to first talk about some of the research, some of the effects of nicotine and what the research has been showing us to inform the program that we are in, I think, our 3rd or 4th year of running, the Healthy You Healthy Baby program. And then I'll provide you with some resources. This is not an exhaustive list of the resources that are available, but we'll show you a couple of them as well. And then happy to answer any questions or provide more information about our programs in general. So to get started, I want to look at the increased vulnerability, the health risks, how the industry targets the population and talk a little bit about these things for a minute. So pregnant and postpartum people are highly vulnerable to either continuing nicotine use or starting nicotine use during this period of their life. There is more stress and things like that that come up when somebody is pregnant or postpartum, that can increase their want and desire to either try something or to continue that habit. So this happens through lots of industry messaging. The tobacco companies have for years created messaging that either will normalize or have the illusion that there's a reduced risk of using certain products during pregnancy than others. They've for years talked about safer alternatives to cigarettes through vaping during pregnancy and things like that. But we just want to make sure everybody is aware that there's no safe level of use of nicotine during a pregnancy. Nicotine use can lead to health risks, including low birth weights, other birth defects, and things like that. There are also including limited access to cessation. So being that there are lots of other needs during this time in a person's life, cessation can often fall kind of to the wayside until somebody specifically asks for it or requests it from their provider. So making sure that providers are aware of the impact that talking about quitting and cessation can have on individuals in this time of their life is a priority of ours. And then the opportunity for impact, supporting cessation during pregnancy can lead to significant health benefits, both for mom and baby, and those long-term outcomes. So we do a lot of work to make sure that mom feels supported as she is making a huge life change during a really stressful time in her life. So making sure that we are always supporting people where they're at and providing these opportunities, asking the questions that they might not be thinking about or that they might be not being asked by their provider. So just a little bit of the research showing some of the long-term effects of nicotine use during pregnancy. The biggest of those long-term effects are cognitive, behavioral, and respiratory challenges and concerns. Obviously, there is chance for reduced fetal growth and increased risk of preterm delivery. But thinking of some of those attention difficulties, learning issues, a higher risk for ADHD and other related diagnoses comes with a direct correlation to nicotine use during pregnancy. Increased wheezing and childhood asthma can be a result of using nicotine, especially if it is being used in the form of smoking or vaping around a child. Those increased concerns for asthma and other things like that can have an effect on the child for their lifespan. Something that's also interesting to note is that nicotine is able to cross the placenta regardless of the delivery method. So it is able to translate and transfer right into baby regardless of how the baby is delivered. Something that is not talked about enough, and we are still looking into the research about some of that stuff to educate some of our pregnant and postpartum. Okay, so I'm going to take the next portion of the presentation to talk to you. Our cessation program designed specifically for pregnant and postpartum people. It provides extra layers of support throughout the pregnancy, focuses the cessation on the pregnant person and what they're going through, but also how that they're about to go through, bringing in a new member of the family. So I will show you a little bit of the overview of the program. You can see the photo over here is actually from some of the marketing that we did to advertise the program. This was given in the form of flyers. It was used on some of our social media advertisements. But to qualify to enroll in the Healthy You Healthy Baby program, the individual must be pregnant currently or up to 1 year postpartum. So we do not have any other qualifications or income guidelines. We don't ask any insurance information. All we need to know is if the person is living within our service area, and if they are currently pregnant or up to 1 year postpartum, they are eligible to enroll. Through funding through the Department of Health, we were able to offer the program to 8 individuals living in Allegheny County, 8 individuals living in some of our Southwest counties, which are the 10 counties surrounding Allegheny County, and then 8 participants in the Northwest counties. We came up with this number based on the incentives that we wanted to provide, as well as the funding available from the Department of Health. So we are very, very much grateful that we were able to continue this program and receive some extra funding to be able to make it happen in the last fiscal year. You'll notice that some of the incentives that we offer, we classify them as big ticket baby items. In the past, we have offered a range of different types of incentives, ranging from gift cards to a baby list website or other baby stores online, to other kind of like day-to-day necessities, and then other items, that are big ticket that the parents might need, strollers, car seats, things like that for completing the program. The goals of the program were to promote nicotine and tobacco-free lives for pregnant and postpartum people through accessible counseling. So this is not something that we wanted to make more difficult for the individual to join in the way that they would have to make an appointment or show up at a certain time every week. All of our counseling for the program and for our general cessation program is accessible in the way that we offer it over the phone, over video call, through Teams or Zoom, or in person if that's going to support the individual in the best way. So we are flexible with our hours of scheduling the classes. We reach people on their drive home from work at 6 p.m. or before they put their kids on the bus to go to school at 7 a.m. So our counselors are flexible, trying to make the program as accessible as possible so that the mom doesn't have to add one more thing to their plate. The next goal would be to address the social determinants of health among the participants by providing some of those incentives to assist with the transition of bringing a new family member into the fold. So our team was very diligent in the way that we tried to poll moms and to gather information in the form of a needs assessment for what does a new mom really need and what would really help with the transition of becoming a new mom or adding another baby to the family. So making sure our incentives were realistic, but also useful and could grow with the child was a big priority of ours. Making sure that things were not just going to be, given and then thrown away, but making sure that they were actually something that the mom and the family could utilize more than just for that newborn stage. Our last goal was to encourage participants to connect with the resources that are in their communities and with the other participants throughout the quit journey. So we offered opportunities for participants to talk to each other through a support group. This was not mandatory to join to complete the program. It was just another layer of support. A lot of moms had told us that they wanted extra support. They wanted to talk to people who were going through the same thing as them. And then others would say that they just kind of wanted to have this confidential journey, go through it on their own with their counselor. Both were totally valid and accepted. But we wanted to make sure that there was that support there if the mom was looking to connect, with another woman going through something that she's going through as well. So our counselors spent a lot of time thinking about being intentional with creating these support groups and these avenues for moms to connect to each other. Okay, on the screen here is a graphic. So since the program has began, I believe in 2021, there have been 88 individuals referred to the program across our regions. The amount of people that actually wanted to enroll and called us back and started the program, 62 individuals. Out of that, 43 of those participants quit. This was an incredibly successful high quit rate. This is not the quit rate that we often see with general cessation. So we have been super excited to see how effective the program is and to see how many moms came every single week or answered the phone every week, showed up to their video chat every week, and made it all the way through the program. You can see some of the advertising that we did on the left side of the screen there. We advertise it as free coaching and support to help quit smoking or vaping. Every mom wants a healthy baby, and we're here to support your goals. So that is part of our marketing, making sure that we are sensitive to the fact that a lot of moms don't want to be addicted to nicotine, but it's a really hard habit to quit. So adding that sensitivity, making sure we show up without judgment, but just ready to support the moms has been, I think, contributing to a lot of our success. Another thing to mention is that almost all of our counselors that are doing the cessation are moms themselves. So they can connect with a lot of the struggles that the participants are going through. They can relate, they can vent and sympathize with each other, which has added also another layer of comfortability and success to the program. We recruit participants from a variety of avenues. A lot of the recruitment happens either at a community event or through a partnership. So some of our referral sources are listed on the screen here. This is not an exhaustive list of everything, but I would say the Beverly's Community Baby Showers, which is a nonprofit organization here in the western part of the state, have been essential to connect us with moms who are looking for support and help in other areas of their lives. We also receive referrals from recovery centers. Like most of the presenters were mentioning earlier, any type of treatment program, we are always looking to get into to provide support for that. Here are just a couple of photos of some of our staff and some of our participants, as well as our marketing. I just showed a sample of the flyer up here. So this is posted on doctors' offices' walls. It's brought to every community event that we go to, and it is shared among providers as they are going out to coalition meetings and meeting with other providers and things like that. So we have lots of these flyers floating around, as well as these resource guides. So understanding that the moms are going through way more than just a nicotine addiction or dependence. So putting together some resource guides intentionally for some of the other resources that they might need to access through the county that they live in is a priority of ours. You can see the Allegheny County Resource Guide over on the screen here. The categories of mental and emotional support, breastfeeding and infant care, financial assistance and other essential needs, and then community education, parenting needs, support groups, all of those things are wrapped up into that bottom section down there, really just providing that layer of support for the mom to turn to if she doesn't know where to go for resources. All of their participant materials include a workbook where they can work through the Smoke Free for Life program, and then some of these supplemental resources as well. So just other ways that they can remember how to handle stress, how to stay smoke-free, nicotine-free, vape-free, contact information, things that they can remind themselves about if they quit before baby is here, how that can benefit them and baby. One of our staff put together a hospital bag checklist because it was something that they realized that they would have really utilized had they been given it. So just being sensitive to other things that the mom might need to receive to take more of that stress off their plate as well as they're making this huge life change. I'm going to skip through some of these pretty quickly just for time's sake, but there are some partnerships listed on the next couple slides of some of our biggest partners. So the Maya organization in Allegheny County is a great partner that we provide these quarterly cessation groups with. So every quarter throughout the year, we start a new group for moms who are looking to quit. Same with Healthy Start here in Allegheny County. The mission of the organization is to improve maternal and child health outcomes. So all of our flyers for our program are embedded into the resource bag that every participant receives. as they are enrolled in the Healthy Start program. So we have a great partnership with them there. And then just wanted to share a couple testimonials from clients over the last year. So obviously their information is hidden for confidentiality, but if you would just take a second to read, maybe one or two of these, it really speaks to the success and the impact. This is just a start to the feedback that we get for our counselors and all the work that they provide and do to make people feel better in general. So we have a really great team full of, like I said, moms themselves that are great advocates and counselors for people who are going through the program. And just sharing a little bit of data here, we've gotten really great results, quantitatively and qualitatively from our participants. The most important one I think to point out here is that every participant who has finished the program has remained, decreased, or completely stopped their nicotine use at their follow-up calls. So we follow up 1 month after the program is finished, and then 3 months and 6 months. So have either decreased their use or stopped altogether, which is a really great sign. I will skip over through some more survey results. Most of the participants were extremely satisfied with the aspects of the program, and most of them also received some of those additional supports. A lot of them in healthcare and food insecurity, but also with housing assistance, referrals, and then childcare as well, which was really the program, including more frequent visits and check-ins, maybe monthly in-person meetings. Our counselors have heard that they have been requested to do more in-person events and meetings, meet up with the clients to just check in with how they're doing, because they spend so much time building those relationships. I think it can be a difficult transition when the client doesn't have that weekly accountability from their counselor after they finish the program. So maybe doing some more of that in-person kind of activity. Advice and connection to other support services. So looking for more resources in the area that they live to connect to, using their cessation counselor as kind of a liaison to navigate some of those resources and some of that care navigation stuff. And then extra classes for somebody who might need it, and doing something fun together as a group, which was a really great suggestion. So maybe getting the participants together for those who would want to be in person and meet each other, just like doing something fun as a group of people who have just accomplished a really difficult feat in their life, and just kind of give them that support along the way. So our future plans that we're currently working on now is to develop more of a structure to incorporate the partner of the mom into the program. So a lot of our moms say that their partner, their husband, their spouse, their co-parent is a nicotine and tobacco user, and they want support for them as well, so that the whole family can make that change together. So we're working on a framework and a support system to try to make that happen in our program, as well as developing a framework for the past participants to become mentors to new participants. That peer-to-peer education is essential. We've talked about it, all day today, about how you need to utilize the people who really have that lived experience and have gone through similar situations to be those mentors and advocates for new participants. And then creating an educational webinar series with some of the resources that are available in the counties, so that moms can either tune in live or have a recorded version of topics that they might need to learn more about, like car seat safety, water safety, medication dosing safety, and things like that. So trying to engage the community and the providers more to connect with our clients. I don't have a ton of time left, but I did want to just put out there that the PA Free Quit line is a great resource for either pregnant people or general individuals who are looking to start that quit journey. The counseling through the quit line is also totally free of cost. It happens over the phone and you are connected with a counselor almost immediately if you are scrolling through that website and decide to sign up. So it's a great resource available there in the community through across the entire state of Pennsylvania. And then Adagio Health medical offices, I listed the counties in which we have medical offices below. So like I said, we are on the western part of the state, but our medical offices have incredible connections to reproductive health care, pregnancy and postpartum care, STD, STI testing, vaccinations, things like that for the whole family. So we have just wanted to plug that there for a minute, that our medical offices are a great asset to the community as well. And again, if you are interested in learning more about the nicotine and tobacco services that are provided in the region in which you live and work, I have listed the contact information for the other regional primary contractors here on the screen. Adagio Health covers 3 of the regions, but there are other contractors that cover the rest of the state. So if you're looking in more of the central part of the state, American Lung Association is the regional primary contractor there. The Philadelphia Department of Health contracts for Philadelphia County. And then in the southeastern area of Pennsylvania, everywhere besides Philly, Health Promotion Council is the contact there. So this can be shared out to all of you. These slides as well can be shared out. But that is all I have today. Thank you so much for your time. Happy to answer any questions, but really appreciate all of your attention and hearing about our programs for pregnant and postpartum people looking to quit nicotine and tobacco.
Hi, I'm Lisa. Oh, yeah. Hi, I'm Lisa Verbos. I'm the Division Director for Treatment, Prevention, and Recovery here at Department of Drug and Alcohol Programs. I want to thank all the speakers today. This was amazing, amazing. Kept me riveted to the screen, and always happy to have a moment where we can showcase all the great work going on across Pennsylvania. So thank you all. Big round of applause to everybody for sharing. We will be sharing these slides out once we get information together. I did see some a request for maybe like a little fact sheet or some kind of information handout where we can kind of get everything in one space. So that's something we can definitely look into doing for you all. Also, just want to let you know, we are looking always to improve and expand this meeting to make it useful to all of our participants. So you will notice that a survey will be dropped into, oh, Kelly just did it. The survey is there in our comments section. Please take a moment, fill it out, be thoughtful. We do read all your comments. Our goal here is to make this informative, give you all a chance to shine. Randomly each year, we'll choose different people to present. But we want it to be a good use of your time. So please do give that feedback. Any other questions or concerns, let me know. Feel free to unmute or drop them in the chat box. If not, I want to thank you all. Wish you the best wrap up to the end of your year and holidays if you celebrate. And looks like you get 13 minutes back of your Wednesday morning. Thank you so much.
Thank you, everyone.
Thank
Thank you, everyone.